Two-thirds of women with high-risk breast cancer currently get chemotherapy they don't actually need. In this video, we're going to show you a new genomic test that proves exactly who can safely skip it.
This study was formed to see whether a group of women with early breast cancer who would currently be receiving chemotherapy can safely avoid it.
But how do doctors know exactly who can skip chemo without risking their life? The answer lies in a 50-gene test called Prosigna. Here are the practice-changing results.
The patients were selected on the basis of having hormone receptor-positive, HER2-negative early breast cancer. Traditionally, those women who have high risk of recurrence based on the lymph nodes under their arm, what we call the axilla, being involved, or a large tumor size, they would have chemotherapy to reduce that risk. The difficulty in the past has been how to select these women that could avoid the chemotherapy. We now have a generation of genomic assays, and these are tests whereby a small part of the tumor that is removed at surgery can be analyzed because they have a high risk for the expression of multiple genes. In this study, we use a test called Prosigna, and it assesses the activity of about 50 genes and their expression. And from that, we'll identify whether patients have a high score or a low score. So we set out to test the hypothesis that if you had a low score with Prosigna, you could avoid having chemotherapy. So in the study, patients randomly were in one of two arms. In the control arm, these patients had what is standard of treatment for high-risk women at present, which is to have chemotherapy and hormonal treatment. The test-directed arm, also known as the experimental arm, if the women had a high score with Prosigna, they had chemotherapy. If they had a low score with Prosigna, they did not have chemotherapy. Importantly, the patients did not know whether they were in one arm or the other, and their doctors also did not know. So what we saw was that about two-thirds of the women who had the Prosigna test had a low score. So in the study, two-thirds of women avoided having chemotherapy. That's really important because currently all of those women would be having chemotherapy, but in the study, they avoided having chemotherapy. So we followed these women for a number of years, and so far we have been able to demonstrate that those women who avoided having chemotherapy did not have any disadvantage compared to the women who did have chemotherapy. So what that is telling us is that a lot of women who currently receive chemotherapy can safely avoid that chemotherapy. In this study, we went up to 9 involved lymph nodes, which is a very high risk of having a recurrence of breast cancer. We had a small number who had no lymph node involvement, but the majority of patients had those involved lymph nodes. And this is the only study that has been done with these genomic assays that included patients with 4 or more lymph nodes. In the OPTIMA trial, two-thirds of the women were postmenopausal and one-third of women were premenopausal. It is very important in the premenopausal women to make sure that the effect of chemotherapy was truly because of the chemotherapy effect on the cancer and not because chemotherapy, as we know, can damage the ovaries and have a hormonal effect. So what we did in this study is that women who were premenopausal, they also had ovarian suppression using monthly subcutaneous injections. And this is different to some of the other studies that have been done with genomic assays who did not control for the ovarian suppression. There were both local recurrences and also distant recurrences. The distant recurrences clearly are the more important ones. The number of distant recurrences was the same as in the patients who had chemotherapy. So we do not have any more distant recurrences by avoiding chemotherapy. And that's an important result.
I believe this will be a practice-changing trial. At the same time, in the US, we have more experience with other tests like Oncotype. Even MammaPrint is sometimes used. So why did you choose Prosigna for this study, OPTIMA?
Well, we did a feasibility study with 400 women, and in order to be able to demonstrate that, first of all, we were able to do such a study, and it was acceptable to women with high-risk disease. And also, we compared a number of different tests there, and we decided to go with Prosigna because for us, there was more value of information to be gained from using Prosigna because there had already been other studies being planned and ongoing with Oncotype.
Yeah, with Oncotype particularly, we've done two major studies, the TAILORx in patients with negative nodes and the Responder with patients with positive nodes. So how is OPTIMA different or
Yeah,
similar to Responder?
yeah. Responder clearly was with a different test, the 21 gene oncotype test. In Optima, we did the 50 gene test, which is called Prosigna. There are some differences in the study though. First of all, in Responder, the women had either one, two, or three involved lymph nodes. In Optima, we had those women, but additionally, we had women with a high risk of disease burden, women with 4 or more lymph nodes, up to 9 involved lymph nodes. And this is really important to be able to see, can you avoid chemotherapy in that high risk, very high risk group of women? The other difference that we had with the Responder was that in the premenopausal women in Respondent, they did not control for ovarian suppression, but in the Optima trial, we did so using subcutaneous injections of GnRH agonists.
I also heard about the concept of testing a test,
Yep.
which we did not do in Responder.
Yep.
So I'd like to know how,
Yep.
what is that? What is
Yep.
testing the test as opposed to a treatment, for
Yep.
example, and how was that was different from these
Yep.
two studies? And also, if you could comment on the chemotherapy
Yep.
prediction ability of these tests as opposed to purely prognosis.
Yeah. In Responder, the randomization was made after they had the result of the oncotype test. So if they did have a high score, they had the conventional treatment. But if they had a low oncotype score, then they got randomized. But that meant that the patient and their doctor knows what the score is and what the treatment is. And there is a concern that that can introduce biases into the study and the interpretation of the results. The way that our study was done, which is different, the patients were randomized before we knew the results. So the randomization was half the patients had control arm, chemotherapy and hormonal treatment, and then the other half were in the test-directed arm. But the patients and the doctors did not know that whether they're in the control or the test-directed arm. So that removed any biases in the interpretation of the results. And we had less patients who chose to do a different treatment to what they had been allocated.
Prosigna is FDA approved in the US. It's not as commonly used because they were lacking prospective
Yep.
randomized trials. They have excellent data showing how they can predict prognosis in large retrospective studies. So this would open the
Yep.
possibility of using this in the adjuvant setting. And that's why I think it might be practice changing because it's already a test
Yep.
that we can use in the US if we choose to do
Yeah.
that.
The other difference between the Oncotype and Prosigna, for Oncotype, all of the tests have to be done in one laboratory in the world, while Prosigna is done in individual countries and anybody can buy the machine that can do the test. With Prosigna, you also get the subtype of cancers. So in estrogen receptor positive, HER2 negative cancers, they can be divided into what is called Luminal A and Luminal B. The Luminal A, they tend to have more sensitivity to hormones and they're believed to be less sensitive to chemotherapy. But in this study, we made the randomization based just on the score of that is produced, not on the subtype. But clearly, the majority of the patients who are high score would have been the Luminal B patients. But in future, we will analyze our data also by the subtypes and see whether we're getting extra information by looking at the subtypes.
Is it possible that you're identifying mostly luminal A cancers, or there may be some luminal Bs that also have a low
Yeah.
score and therefore would not benefit from chemotherapy?
Yeah.
Because there's this idea that if you divide the estrogen receptor HER2 negative
Yeah.
tumors into luminal A and luminal B, it seems that only the luminal Bs benefit from chemotherapy. Is
Yeah.
that true?
The majority of patients with low scores are likely to be Luminal A. The majority of patients with high scores are likely to be Luminal B. But there is an overlap there, and there are some patients with Luminal B and low scores, and some patients Luminal A and high scores. The proportions within our study we don't know yet, but we have the data and we'll be analyzing that. And then it will be important to see, does the knowledge of having the subtype in addition to the score, give you extra predictive ability to see who does not need chemotherapy.
Another issue we looked at in large randomized trials in the US, for example, the RxPONDER trial, looking at different types of chemotherapy, whether anthracyclines would have a benefit if the recurrence score is greater than 31, for example. Have you or will you be able to analyze different types of chemotherapy, or is all in one?
No, we've collected the type of chemotherapy, and in the duration of the study, there's been a big move away from just anthracycline chemotherapy, schedules like FEC, and more towards anthracycline plus taxanes. Most patients now who have node-positive disease will be getting combinations of anthracycline and taxanes. There's also been another change in the time of the duration of the study, in that dose-dense chemotherapy is more likely to be used than was previously. The other change that has happened is that in the last couple of years, there's been the introduction of the CDK4/6 inhibitors, and that was largely abemaciclib. And towards the end of the study, high-risk patients were also receiving, whether the patients who do not get chemotherapy can safely have abemaciclib or another CDK4/6 inhibitor without chemotherapy. It cannot tell you that.
Is this study going to change practice in the UK?
Yeah, in the UK, we are now going to ask the body called NICE, who approve all the new treatments, to extend the authorization that we currently have for Prosigna, which is postmenopausal women with node negative or up to 3 positive lymph nodes. We want to extend that to the group up to 9 lymph nodes, and also to include premenopausal women. And we're hoping that that authorization for us to go and use this test for all these women in the NHS will not take a long time to come, because it's clearly a very important result, because for the women, they can avoid having chemotherapy if they don't need it, but also we have big pressures on our chemotherapy unit. We're struggling to give all the extra treatments for all the different cancers that are coming through at the moment. So being able to avoid doing some treatments is important, but also within the UK system, societal costs of treatments are very important, in the sense that if you're not giving one treatment and you're saving on the cost of that, you can use that money to do something different in healthcare.
So as we saw today, the OPTIMA study is likely to be practice changing in women with early stage estrogen receptor positive, HER2 negative breast cancer at high risk, meaning positive lymph node involvements, and it works both in premenopausal and postmenopausal patients. It's great to have a new test that we can use in our patients moving forward. So thank you very much, Dr. Mack.
Thank you.